Hi, xin chào. My name is Clementine Vo. I love how everyone's eyes just perked up. Oh, she speaks Vietnamese. As he said, I'm a pediatric cardiac anesthesiologist in LA. If you're anything like my parents, you think that I just put patients to sleep and maybe go to sleep with them, or as Americans say, ABC, airway breathing chair, instead of airway breathing circulation. But as a pediatric cardiac anesthesiologist, my job is so much more, or at least I'd like to hope so. I'm here to talk to you about truncus arteriosus, which, while is not one of my favorite congenital heart lesions, is one that humbles me quite frequently, sort of like the really bad severe pulmonary hypertension kid or the heterotaxy Fontan that comes in with PLE and plastic bronchitis. This is one of those cases where my ears perk up and I say a little prayer before I take them back. I have no disclosures. So a little bit about a history of truncus arteriosus. It was historically described back in the early 1800s, but it really wasn't classified until Drs. Collette, Edwards, and Van Praagh came along in the 1950s and 60s. Unfortunately, because of the lack of advances in medicine, specifically with deep hypothermic circulatory arrest and cardiopulmonary bypass, we weren't able to do much as a team until the 1970s, where the first repair was done. Prior to that, or in the early 1970s, it was primarily palating these patients with a PA band. Now, thankfully, it's a pretty uncommon lesion. It only accounts for about 1 to 3% in all congenital heart lesions, and is more frequently in males. It is associated with some maternal exposures with cigarettes, contrast dyes, and as you probably already know, very commonly associated with the George syndrome or chromosome 22q11 deletion syndrome. It all comes back to when the fetus is about 7 to 8 weeks of age. As you recall in medical school, your 6 pharyngeal arches all mature and are supposed to become either regress or mature to become a vascular structure. If the 4th and 6th pharyngeal arch fail to become the aortic arch and right subclavian for the 4th, and for the 6th, the pulmonary artery and patent ductus arteriosus, you have failure of truncal septation leading to this persistent common arterial trunk. There are 2 classification systems. The first is the Collette and Edwards, and the second is Van Praagh. Just for simplicity's sake, I will refer to the types using Collette and Edwards, but I wanted to point out that the type Van Praagh A3 and 4 include aortic arch abnormalities, which are present in about 20% of these cases. So important to us as the anesthesiologists, and of course to the intensivists as well, or the cardiologists, because of the ductal dependency there and the need for a prostadome. Now, type 1, just a refresher, is when the pulmonary arteries come off from the base of the main arterial trunk. Type 2 is when the branch arteries come off posteriorly. Type 3 is when they come off laterally. And type 4 is when they come off of the descending aorta. Type 4 is sort of fallen off of the face of the earth in terms of being classified as truncus, and it has been redefined as TOF with MAPGAS. Now, I just wanted to bring your attention to type 1, which is the picture on the right here. I think it's a great depiction of type 1, although with hypoplastic PAs. One of the biggest concerns of an unrepaired truncus arteriosus in these patients is unrepaired, those PAs will get torrential pulmonary blood flow and will get a lot bigger, leading to congestive heart failure, and is actually what accounts for most of the mortalities cases in these patients when they're less than 6 months of age. Now, by definition, it's classified or defined by 3 defects. You have a single semilunar valve shared between the aorta and the pulmonary side, and this can be anywhere from 3 to 6 to 7 cusps. Normally, or I should say most commonly, it has 3 cusps, and 4 cusps is actually associated with a greater mortality rate. It also has a subarterial ventricular septal defect, and most importantly, it has a circulation that mixes in the ventricular level for the most part and divides into the aortic or the systemic circulation, the pulmonary artery circulation, and the coronary artery circulation. I always tell my students that to always kind of look at these patients with these circulations in relative competition with one another, because as you have more blood flow going to one area or to the coronary circulation, for example, you'll have less going to the lungs and vice versa. Now, there's quite a bit of associated defects with truncus arteriosus. Most commonly, you have a atrial septal defect, which is present in 90% of patients. And this is actually a good thing, as I'll go into later on. Post-repair, one of the biggest concerns of these patients is having a pulmonary hypertensive crisis. So by having an atrial defect, you allow for that right to left shunting across that atrial level to kind of take that pressure off of that right ventricle as a pop-off. If this isn't already large enough, the surgeon will create a atrial septectomy on the field. Half these patients will also have coronary anomalies, and this is important to really notice, not just as the surgeon, but also the cardiologist, because some of these patients can have an abnormal coronal branch coming off, and where does this run across? This runs across your RVOT, or your right ventricular outflow tract, and that's usually where he or she, the surgeon, will make their ventriculotomy. Some of these coronary origins will also be abnormal. They may come off from an abnormal facies, or take an abnormal course, such as an or intra-arterial, or intramural, I should say, course. Now, as far as syndromes are concerned, there have been reports of association with trisomy 21 and trisomy 18. Those are mostly post-mortem. Most commonly, these patients have the DiGeorge syndrome. When in doubt, I always say assume that they have the DiGeorge syndrome. And why does it matter? It matters because as the anesthesiologist, there's a few things. With the abnormal facies, you typically have a cleft lip or a cleft palate, leading to a potential difficult airway. They also have an absent thymus, leading to immunodeficiency. Now, at our institution in Los Angeles, for all of these cases, we will leave the sternum open and close it at bedside in a few days. So that, of course, already puts the patient at higher risk for having a sternal wound infection or mediastinitis. And then you also have the hypoplasia of the parathyroid glands, leading to hypocalcemia. Remember in a neonatal myocardium how important calcium is for that immature tibial system. All right, now let's get to the fun part. At the patient's birth, he or she will take his or her first breath, PaO2 will increase, pulmonary vascular resistance will decrease. Sometimes this, originally at that first breath, it's quite a dramatic drop, but it will continue to drop over the course of the next few days, unless, of course, you have a persistent pulmonary hypertension of the newborn. This is your typical picture of a type 1 truncus arteriosus with truncal valve insufficiency. This will bump your mortality rate from what started at 10% to times 6 to 60% if you have truncal valve insufficiency. And as you can see, the danger there is that not only do you have blood stealing from your coronary circulation or / your systemic circulation, but you have that truncal valve insufficiency leading to quite a bit of LV dilation and left atrial hypertension, where is it going to go? Just backwards to your lung, leading to congestive heart failure and significant pulmonary edema. So unfortunately, without repair, most of these patients will be dead within 6 months of age. There are some study reports out there that have shown adults that survive into the 40s, 50s, and 60s with this lesion, but of course, it's because they have some sort of lung protective measure, such as with pulmonary artery stenosis. In this patient right here, where you have your venous blood coming back from the right side is systemic from your left side, mixing at the ventricular level, so you can see you have more blood flow from that, or purple blood, if you will, going out through your aorta to your pulmonary arteries. So you can expect this particular patient in front of you to be quite cyanotic, but to have decent pulses distally. This patient right here is the reverse. You have more blood flow going to the pulmonary arteries and less to the systemic circulation. So you might think, oh, that's great, they're pink. A lot of my students tend to be like, oh yeah, it's great, they're on room air and citing 95%. Not exactly the best situation, because what does that mean? It means that they have less coronary perfusion, they have less end organ perfusion, probably lactic acidosis, probably necrotizing enterocolitis. So it's not uncommon that we will try to take over and intubate these patients and hypoventilate them intentionally. Just wanted to go back to this photo or this animation of the patient with truncus arteriosus and severe truncal valve insufficiency. One of the biggest things to note is with that truncal valve insufficiency, once again leading to the LV dilation. Remember with basic equations that we learned back in school, that coronary perfusion pressure is equal to the aortic diastolic pressure minus the left ventricular end diastolic pressure. So what does truncal valve insufficiency do? It increases your LVADP, and then that steal that you have from your insufficiency and seal into your PAs decreases your aortic diastolic blood pressure. So essentially, you have a cocktail of a disaster for a myocardial infarction. Now, how do these patients present to you? It really depends on where they are in the process of their pulmonary blood flow or pulmonary vascular resistance dropping and where their pulmonary blood flow is going. Pre, you might see them a little bit mixed, which is good in my opinion, but then after that falls, that's kind of like where you want to be a little bit more cautious about how you approach them from an anesthesia perspective. These are the patients that are tachypnic, tachycardic, that fail to thrive. They're coming to you, but they're pink is what everybody says, and you know, he seems so excited about that, but it's actually not that great. Diagnostically, it's mostly just done with echocardiogram. Advanced imaging techniques such as with CT or MRI are only necessary if there's some aortic arch abnormality that needs to be delineated or coronary anomaly that you suspect. But for the most part, once again, just a transthoracic echocardiogram will do. You can appreciate on chest X-ray that you have that cardiomegaly, the widened mediastinum from the right-sided aortic arch, and the pulmonary edema in that photo right there. All right, so what do we do? So this lesion is really a surgical lesion, but instead of taking them to the operating room right away, we will settle them down, if you will, in the ICU by giving them medications like diuretics to improve their respiratory status. We'll intubate them, we'll intentionally slightly hypoventilate them, put them on just 21% FiO2 to minimize any distal hypoperfusion. We'll support them with inotropic agents such as dopamine or epinephrine, and start alprazolam if, of course, they have a severe coarctation or if they have an interrupted arch. Now, surgically, once they have settled down, what we'll do is we'll just basically add holes where there should be and close holes where there shouldn't be. Sounds easy peasy enough, but not so much. I'll just kind of walk you through what our surgeons at Children's Hospital of Los Angeles do for a type 2 repair, for example. Now, after sternotomy, they'll quickly notice whether or not a thymus is present. They'll harvest that pericardium to close the VSD patch, and then they'll quickly expose the aorta and the great vessels, particularly the PAs. And this is important because with induction of anesthesia, as you can imagine, the afterload decreases, and it's essentially a huge cocktail for having ventricular fibrillatory arrest. So we want to make sure that the PAs are as exposed as possible so they could put snares in, which are, as you can see with these blue loops that I've put in, and tighten them. We call them PA snares, if needed, if there's any suspicion of poor cardiac perfusion. The red lines are just to kind of point out where the cannulation sutures would be. After we go on to bypass and after the PAs are snared, we'll cross-clamp the aorta, being careful to, being right here, being careful to just leave enough space for the resection of the PAs as a sleeve in this photo right here, but just right underneath the innominate artery. The surgeon, after arresting the heart, which remember with truncal valve insufficiency, you're going to want to make sure that you arrest the heart not just through antegrade, but also through direct injection into the coronary arteries or through retrograde cardioplegia. He or she will decompress the left ventricle of the heart by placing a right atrial vent that crosses the defect into the mitral valve and into the left ventricle. He or she can also place a right superior pulmonary vein vent to also do the same trick. Nonetheless, LV decompression is extremely important. Once the heart is adequately protected and decompressed, during this point at our institution, we'll usually cool down the patient to 18 to 22 degrees, 18 if we're going to go on deep hypothermic circulatory arrest, which is a whole can of worms in and of itself, which I won't go into. But here, the surgeon will then proceed by performing the ventriculotomy, closing the VSD patch, repairing any truncal valve insufficiency that needs to be done, and then essentially anastomose where things should be. Sounds easy enough, right? But just remember that all these coronaries are very close to the branch PA. So when he or she comes in to do a resection of that PA sleeve, or just this little section right here, remember that that left coronary orifice is extremely close to where their scalpel is going to be going. So just be very conscientious of that. Type 3, same thing. I thought that this was pretty cool because it was just a nip and tuck kind of a situation. Now, as far as anesthesia management is concerned, can be a little tricky. Pre-bypass, there's a few considerations. As far as access is concerned, what we'll do besides your standard ASA monitors of EKG, blood pressure, oxygenation, et cetera, are things like a CVP or an internal jugular central line and an arterial line. That arterial line has to be placed with considering whether or not you have an aberrant subclavian artery, which can be in about 20 to 30% of these patients. My goals as the anesthesiologist is to keep everything within normal limits. It's to maintain normal sinus rhythm. I want to do this without increasing the heart rate too much by increasing myocardial oxygen consumption. And then most importantly, going back to the coronaries, I want to maintain coronary perfusion pressure. I can obtain this by, if they're not already ventilated and intubated, I will pre-oxygenate them on 100%, intubate them. Once I've established that airway and I'm 100% in where I should be, I will bring that FiO2 down. I will hypoventilate them and drive that end-tidal CO2 up to usually in the high 40s and 50s to ensure that I'm creating sort of like a medical PA band by increasing PVR just a smidge enough to make sure that my coronary perfusion is not compromised. I always call this the temporary or the anesthesia PA band. Back in the day at our place, maybe some places still do, I'm not quite sure, but we will also have a CO2 line, carbon dioxide line, that you can actually entrain into the endotracheal tube to raise that even more. That's what some of my mentors used to do after inducing a patient with HLHS, or hypoplastic left heart syndrome. Now, one of the reasons why it's one of the lesions that keep me humble is because a study coming out of, well, besides it's obvious, studies coming out of Boston Children's looking at 5,000 anesthetics have shown time and time again that patients with truncus arteriosus undergoing cardiac surgery repair consistently show up as a higher risk for having a coronary event. Now that the surgeon has finished the procedure, everything's great, right? Well, not quite, unfortunately. These patients are at higher risk for arrhythmias. Because of that VSD closure, you're always at higher risk for having a second or third degree heart block. For all these patients, we always have atrial and ventricular pacing wires temporarily, and only remove them later. But the patients are also at higher risk for malignant arrhythmias, such as VFib or VTAC post-procedure. If this were to occur, your biggest concern would be, did the surgeon do something to the coronaries, or is there kinking? Did he or she try to close the chest and there's kinkage that way? So you just want to be keeping that in mind all the time. Of course, you want to maintain contractility at our institution. We use 100% FiO2 coming off bypass, 20 parts per million of inhaled nitric oxide, dopamine, calcium, epi, and milrinone. Preload and hemostasis is a huge problem in these patients. These patients are typically less than a week old, so their livers are quite immature. They have that typical neonatal coagulopathy issue where they just keep bleeding and bleeding and bleeding. And then that's just made worse by the fact that we've cooled them down to about 18 to 22 degrees. All the cardiologists kind of cringe when I admit this, but it's not uncommon for us to end up giving about 100 cc's per kilo in a 3-kilo patient, for example, undergoing one of these procedures. Now, of course, the blood coming in is always going out somewhere, unfortunately. You'll want to also have a transesophageal echo probe in during this time to take a good look at not just residual defects, but what does that truncal valve now look like? Is there truncal valve stenosis now that we've repaired the truncal valve? You also want to look at your biventricular function. Look at that RV. Is there septal flattening, or is there any concern of pulmonary hypertension, which is quite common for these patients postoperatively. We always place these patients on 100% in nitric oxide coming off bypass and only weaning them a few days later. Now, it's actually quite uncommon for us to necessitate starting sildenafil or anything like that long-term wise, but at least for that acute initial postoperative few days, you definitely want to keep that in mind. And then associated symptoms and their comorbidities such as with chromosome 22q11. At the end of the day, support the RV, support the RV, support the RV. Epi, milrinone, and nitric oxide are my best friends. And that's really because once you've gone down that road of having a pulmonary hypertensive crisis, RV failure, LV failure, I've seen that mostly just ECMO can take you out of that, at least for the first few days until the patient settles down. Short term, again, pulmonary hypertension. Just keep that in mind. Bleeding, arrhythmias, RPA compression can occur with the sternal closure that happens within a few days. And then long term, this is where Dr. Mike Sharofsky comes in, is that he has to address the RV dilation that occurs over a long period of time if there's conduit stenosis and things like that. So unfortunately, it's common for these patients to come back to me to the operating room having their 5th, 6th, 7th reduced sternotomy because now they need a new valve across their conduit, and for some reason they're not a percutaneous candidate. Now, you might think, oh, I'll never have to deal with this, or some anesthesiologists, they think, I never have to deal with this. Unfortunately, we still do. These patients come to you unrepaired for a congenital diaphragmatic hernia or for a tracheoesophageal fistula, and you still have to maintain those hemodynamic goals as you did pre-repair. This is a little patient who had truncus arteriosus type 1 and severe truncal valve insufficiency. She was deemed to not be a surgical or ECMO candidate, so a lot of people were just, okay, hands off. But she had this tracheoesophageal fistula. So within day of life 2, we took her back, did the TEF repair, and surprisingly, she did so well that our cardiac thoracic surgeons decided, let's go and try to repair the congenital heart lesion. And as you can see on the sternal scar, they did, and she did well from a cardiac perspective, but unfortunately still passed away a few months later to her other comorbidities. But I thought, I'll never do a truncus patient without thinking of her again, pretty much. Now, unfortunately, the outcomes don't look so great. The mortality rate is still surprisingly pretty high, in my opinion, at around 10 to 12%, with this doubling if you have any arch associated abnormalities, and this is like the interrupted arch, not the right subclavian artery. This number is multiplied by 6 if you also have truncal valve insufficiency. So not great numbers. Even when they've made it past their neonatal repair and in their first few days of life, unfortunately, they still come back a lot. The median age of return is 5 years after the initial operation, and this is typically secondary to needing an RVOT replacement, but it could also include things like angioplasty stents in the cath lab. You can see that by age 14, basically 100% of these patients are not free from operation and have had some kind of intervention or re-intervention done at one point or another in their lives. This was a study that came out also in Boston in 2021 that looked at our mortality rates for, or looked at how frequently patients would come and what the single highest factor was. And it was always pointed back to patients having quadricuspid valves and patients who had an initial size of 10 millimeters or less done at the initial repair. Now, unfortunately, when these patients come to you, they're 3-4 kilos. I've had a truncus arteriosus patient come in, and she was 2.2 kilos. You can't exactly put in a 60 millimeter conduit in there. You can't exactly send her to see Dr. Sharofsky and have a Melody valve placed in, right? So unfortunately, we're still dealing a lot of those issues. It's on this study, I believe, with less than 11 millimeters of a conduit, the mortality rate was at 22%. It would only come down to about 11 to 12% when it would be a size of 13 millimeters or more, which again, you can't exactly easily do in a patient who's only 2.2 kilos. So what can we do about it? This is a picture of a 4-kilo baboon with a partially xenotransplanted RVOT patch that we placed, or valve that we placed a few months ago in a genetically engineered pig. So every time I give this lecture, I'm always kind of curious, if we can't exactly be placing 12, 13, 14 millimeter sizes in these children, could we place a genetically engineered partial xenotransplant RVOT in these kids and hope that it grows with the child? So far, the data looks okay. I don't want to say too much about our research project, but it's in its works, and there's been shown to be some success with it. So hopefully, this will help us with the supply issue in terms of neonatal supplies of donors and valves and things like that. But that's pretty much all I have for you. Thank you.